Hi, and welcome to a multidisciplinary approach to screening and managing peripheral arterial disease. I'm your host, Dr. Desmond Bell, and we have a really exciting evening planned for you. So we'll get right to it. I don't know if you're aware of this, but September is PAD Awareness Month. This is really what's driven this whole concept tonight. This program was really created in conjunction with the Save a Leg, Save a Life Foundation and our White Sock campaign. Our vision is to increase awareness of PAD to the public and really get some of these patients who you're probably seeing in your practice, getting them to the right providers, get them screened. It's one thing to talk about this, but we've got to take action. And ultimately, we want to reduce pain and suffering and unnecessary amputations. So I'm joined tonight by some dear friends and fellow faculty members, Dr. Raghu Kalluri and Dr. Mehdi Shishabor, obviously two giants in our field. Here are disclosures. And we'd like to thank NACME as well as Medtronic for making this evening possible, as well as the Save a Leg, Save a Life Foundation. And our mission is to reduce the number of lower extremity amputations and improve the quality of life of our fellow citizens who are afflicted with wounds and complications from diabetes and peripheral arterial disease. Our objectives this evening are to effectively diagnose and screen for PAD, determine an appropriate treatment pathway for each PAD patient, and to understand the value and utilize a team approach when treating PAD. We've also identified some of our primary care docs and podiatrists, nurse practitioners, and physical therapists, and we want you to also understand some of the issues that surround PAD patients as well as unnecessary amputation, understand the importance of PAD screening, and really we want to improve access to care through optimizing communication and referrals within the interdisciplinary team. So, over the past several years, we've had a real scary thing happen, and this is part of our motivation. We've had an increase in the number of amputations that have been going on in our country. And everyone understands that the pink ribbon in October has come to signify breast cancer awareness. But most people don't understand that PAD awareness is a huge problem. We have over 34 million people with diabetes and 88 million with prediabetes in the US. And despite this, there's really been very little public awareness targeting PAD and amputation prevention. Amputation rates, again, are on the rise. And this is despite improved technology and awareness among the medical community. So where is some of the disconnect? Well, this is why we've created the White Sock campaign and PAD awareness. So you do hashtag White Sock campaign, and we'll talk a little bit more about that in a few minutes. But with that, I'd like to hand this part of the program over to Dr. Raghu Kalluri, who's going to talk about the diagnosis and screening of peripheral arterial disease.
Hello, everyone. I'm Raghu Kalluri. It is an honor to join this team here with Dr. Bell and Dr. Shishabor, both good friends as well. And it is my honor to talk about the diagnosis and screening of peripheral artery disease. Peripheral artery disease refers to atherosclerosis, essentially in the aorta, iliacs, and lower extremities, leading to decreased blood flow and symptoms ranging anywhere from exercise-induced claudication or critical limb ischemia or atypical symptoms, which we'll talk in a little bit. The diagnosis of peripheral artery disease, as most of you know, is made by an ABI of less than 0.9. As Dr. Bell said, the prevalence is quite high. One study showed 10% of population over 55 and a worldwide prevalence of 202 million with peripheral artery disease. Apart from the high prevalence, there is some disparity in terms of PAD diagnosis and incidence in Black Americans as well, which is important to remember. So why is PAD important? Well, there's an inverse relationship with 10-year mortality and worsening ABIs. As you can see in this slide, this is called the J curve, where with normal ABI, the hazard ratio is 1, and as the ABIs decrease to the left of the screen here, you see an increase in the hazard ratio for 10-year mortality. But you see a slight increase here even when the ankle brachial indices are greater than 1.4, which suggests that there is stiffness in the blood vessels, and that may portend increased risk for mortality as well. We also know that at 12 years, the mortality within PAD differs from symptomatic to asymptomatic ones. For example, severe symptomatic patients have a survival of approximately 25% at 12 years compared to healthy subjects who are around 90+%, and asymptomatic patients are somewhere in between, and symptomatic patients are slightly lower than asymptomatic patients. We know that the risk factors for peripheral artery disease, without any question, are smoking, diabetes, hypertension, and hypercholesterolemia. We also know that end-stage renal disease patients also have a high prevalence of peripheral artery disease, and it may be a potential risk factor for atherosclerosis, with an incidence of approximately 25% in this particular study, close to 1,000 patients on hemodialysis. Apart from the prevalence, it also causes a huge economic burden, with direct costs related to PAD exceeding $4.3 billion, out of which 88% are expenditures for the patient's inpatient care. This, when you compare, when you exclude the MI and stroke or rehabilitation, that's approximately $3.9 billion for Medicare expenses, which is higher than dysrhythmias, similar to congestive heart failure, and approximately the same as cardiovascular disease in general. So what are the PAD symptoms? Well, as most of you know, this exertional pain in the leg is called intermittent claudication, described as cramping of the legs that occurs with walking and quickly relieved by rest, classically without having to sit, which differentiates between claudication and pseudoclaudication. And initial claudication distance is where that patient is able to walk pain-free, but then starts noticing the pain. And absolute claudication distance is where the patient needs to stop because of the discomfort. Aeroiliac disease generally manifests as claudication of the buttocks, thighs, while femoropopliteal disease involves the calves. There's Rutherford staging. Again, as most of you know, 0 is asymptomatic, 1 is mild, 2 is moderate claudication. A similar Fontaine classification described this as 200 meters of claudication distance. Stage 3 is severe claudication, stage 4 is rest pain, and stage 5 is ischemic ulcerations on the digits of the toes, and stage 6 is severe ischemic ulcers or frank gangrene, which exceeds just the toe ulcerations. So when you look at the symptomatology again, I mentioned that there are patients who have symptoms of claudication, and then there could be symptoms that are not typical of claudication. So if you look at the total number of patients who are 50 and older who present with peripheral artery disease diagnosis, 20 to 50% are asymptomatic. Maybe they have osteoarthritis, maybe they're not walking at all, and maybe they first time present with a CLI. Atypical leg pain, 40 to 50%, and classic claudication is present only in 10 to 35%, and critical limb ischemia in 1 to 2%. So when you follow the classic claudicants for 5 years, it is interesting to see that the major adverse limb events or limb mortality is not that much. Stable claudication in 70 to 80%, while critical limb ischemia is seen in 1 to 2%. On the other hand, the major adverse cardiovascular events, cardiovascular morbidity and mortality, is significantly higher in these patients, with CV causes up to 75%. So peripheral artery disease by itself is an indicator of a greater atherosclerotic panvascular problem in these patients, and that's why we want to treat the patient as a whole and not just for the peripheral artery disease, especially for those who present with claudication symptoms. So in the clinic, you're seeing patients who are at risk for PAD Well, anyone over age of 65 is at risk for PAD. From 50 to 64, if they have other risk factors or atherosclerosis, let's just say you found carotid artery disease or coronary artery disease, you have to think about peripheral artery disease. Those who have family history of peripheral artery disease is also important. What about younger than 50? If the patient is younger than 50, you want to look at associated risk factors like we talked about, smoking, diabetes, and other risk factors of atherosclerosis. You got to think about peripheral artery disease. And any age group with documented atherosclerosis, like I said, in another vascular segment, coronary disease, carotid disease, subclavian, mesenteric, AAA, you want to ask those classic questions of claudication symptoms and do a good pulse examination of the feet. As I've heard saying, knock their socks off and take a good pulse check on these patients. So the classic findings on examination when you look at these patients that are being described are diminished hair, brittle hair, atrophy of the skin. But these are classic symptoms, and you may not see any or all of these on physical examination, and only finding maybe an abnormal pulse examination, or maybe even the pulse is fine because you won't know until you exercise them. There might be cyanosis if the patient is presenting with critical limb ischemia. There is pallor with elevation. So when you raise the feet up, there's pallor. And then when you lower the feet, there is dependent rubor or redness. Sometimes you'll see livedo reticularis, which is a fishnet type of modeling that you see in this patient here with peripheral artery disease and smoking history. The rest of the times you have patients coming in with critical limb ischemia, as I mentioned, Rutherford 5 or 6, with ulceration or gangrene. When you see these patients, it's not always peripheral artery disease. A great number of my patients, I'm trying to differentiate whether they have true claudication or pseudoclaudication because they have spinal stenosis or nerve impingement. I send a lot of my patients for nerve conduction studies and EMG studies. Sometimes the patients will say that when they walk, their knee hurts, but you're seeing them for peripheral artery disease. So unless you have the osteoarthritis addressed, you're not going to help the patient. Venous claudication is quite similar to arterial claudication, except for the presence of venous insufficiency changes, and the claudication occurs with prolonged standing as opposed to walking. Then there are neuropathy, the peripheral neuropathy, complex regional syndrome, popliteal entrapment syndrome, chronic compartment syndrome, and Baker's cyst, all of those which can result in discomfort with walking, which you need to tease out. And if you see enough of these patients, you'll see all of these in your practice in the 1 to 3 years of your practice. So how do we test these patients? Well, as I said, the diagnostic criteria for peripheral artery disease, an ankle brachial index of less than 0.9. So obviously the ankle brachial index test comes top on the list. You could do exercise ABI. We'll talk about that. Segmental ABIs, transcutaneous oxygen pressure, typically in critical limb patients. We also do anatomic studies such as duplex ultrasound and axial imaging with CT and MR. So as I said, anything less than 0.9 is PAD. Severe PAD is described as less than 0.4 in some labs, some in less than 0.5. Moderate to mild is somewhere in between, and anything more than 1.4 is considered to be non-compressible or stiff vessels. So here is an example of an absolutely normal ABI, which is the higher brachial pressure to the higher ankle pressure, as most of you know. It's 1. On the left side, it is 0.41, which suggests severe peripheral artery disease, as all of you know. And if the patients present with symptoms of peripheral artery disease and they have normal ABIs, and if the resting ABIs are normal, it's very important to check exercise ABI, which is actually by protocol in our lab where I practice. If the patient's pulses are normal on exam, but they give you classic history, probably they have aeroiliac disease. Here is an example of the right ankle where you see once they start exercising, the right ankle pressure goes from 189 to 123, and the ABIs go down to 0.60 and then come back up slowly at 5 minutes. So it is very important. You cannot rule out peripheral artery disease until you do an exercise ABI if the patient is able to do the exercise ABI. What about supranormal ABI, stiff vessels? So here is an example of ABI that is higher than 1.4 on both sides. In this case, we're looking at the pulse volume recordings, or PVRs, which I'll tell you what they are in the next couple of slides. We are also looking at toe pressures and toe brachial index. So pulse volume recordings are plethysmographic tracings that are applied on the patient's cuffs, thighs, or feet, wherever you want to, and inflate enough pressure, approximately 60 to 65 millimeter, to impede the blood flow that is venous, so that only the arterial pulsations are picked up by the plethysmographic sensors in these cuffs. So normal waveform will have a quick upstroke, a quick downstroke, a dicrotic notch, and down. And then that's a normal waveform. For example, in this patient where you have an ABI of 1.43, there's a nice dicrotic notch and then comes down. So that is actually a normal study. Perhaps there is only stiff vessels for other reasons. The first part of peripheral artery disease in stiff vessels where you lose this dicrotic notch is generally called the mild. A flat tracing is severe, and decreased slope where where there is no quick upstroke, there is no dicrotic notch, is considered to be moderate peripheral artery disease. Apart from that, as I mentioned, there are toe brachial index. Toe brachial index is basically pressure of the toe compared to the brachial artery. Anything more than 0.7 is normal. Anything less than 0.25 is considered to be CLI. And any pressure of absolute pressure of less than 30 millimeter mercury is also consistent with critical limb ischemia in most cases. Anything in between 0.25 and 0.7 is suggestive of PAD, which is mild to moderate. Segmental pressure. So if you can also slab these cuffs across the thigh, proximal thigh, mid-thigh, proximal calf, and ankle, and also get where the level of disease is. Here is a patient coming in with an interesting ulcer of the pretibial area from antiphospholipid antibody syndrome. And we note that there is a drop from 120 pressure to 90, and then that is maintained down. So we came up with a diagnosis that it is aeroiliac, and the angiogram clearly shows that the iliac artery is completely thrombosed in this particular situation. What about arterial duplex? Well, arterial duplex is a very easy test for anatomic purposes. It gives you a nice roadmap. It's super easy to do for most sonographers. You're looking for a quick upstroke, a reversal, the classic triphasic or high resistive waveform, and then a forward flow and cessation during the diastole. So this is a clean artery in this situation, an open stent. But when the velocities double up compared to the proximal portion, then we call it a greater than 50% stenosis, as in this case, where the end diastolic also goes up, and you can also see the stenosis in the grayscales. What about axial imaging? Well, axial imaging, at least in our practice, has gone down significantly over the past several years due to the use of physiologic studies and duplex studies, and because most of our practice is critical limb ischemia, and approximately 30% of CLI patients have renal insufficiency, which basically makes it difficult for us to get an MR or a CT, but these are good modalities, and most of our CT and MR is done in outreach clinics where we don't have access to a good vascular, non-invasive vascular lab. So I'll complete my part with this slide. So if you suspect the PAD with lifestyle limiting symptoms or CLI, the first test you want to get is an ABI with or without segmental pressures. Maybe you want to add a duplex to it, toe pressures. If CLI and if the patient has low GFR, I would go to DUS, duplex ultrasound, maybe TCPO2, and go straight for angiography. If it is not, you may want to consider a CT or an MR, or if the patient has history of complex bypasses, et cetera, and you want to have a good map before doing an angiogram, that's another time we would do a CT or an MRI. If it's not CLI, and if the ABIs are greater than 1.4, we go with TBI assessments. And if the TBIs suggest peripheral artery disease, then we get a diagnosis. Otherwise, go through the list of those alternate diagnoses that I've given earlier in my talk. If the patients do have abnormal ABI with lifestyle limiting claudication, obviously that's easy. And if the ABI is normal, like I said, and if you still suspect PAD, do an exercise ABI. And if it is positive, again, you got a diagnosis of peripheral artery disease. So with that, I'll end my talk.
Thank you, Dr. Kaluri. That was an excellent overview and some great information in there. You know, I especially think that that last slide brought home, you know, it answered some of the question too of, well, what test should I order? We hear that all the time. So I think that's a great little starting place too. So one of the very common type questions, which I just alluded to from fellow providers or even in a wound care center, there's sometimes confusion about what tests should be run, but also what tests can be run in an outpatient clinical setting. We might get, I'm going to get into that a little bit later, but from your experience, Raghu or Mehdi, what recommendations do you have? Especially when you hear people say that it's too time intensive to run an ankle brachial index. What recommendations would you make?
I think the value of ankle brachial index, they're so cheap, so diagnostic, and so important. I don't think I see the downside to it at all. And without that definition of an ABI that is abnormal, it is hard to get a diagnosis of peripheral artery disease unless it's critical limb ischemia, in which case, you know, clinical exam kind of, you know, trumps everything. Mehdi, what do you think?
No, I totally agree. I think in a setting of critical limb ischemia, if you have ulcer or gangrene, in that setting, as Dr. Kaluri mentioned, you have to be careful because you can get fooled by the ABI, as many of those patients have diabetes and end-stage renal disease. And as he mentioned, they have non-compressible arteries or collaterals that may fool you. So in that particular situation, I be careful. I will still get the ABI. If it's abnormal, then it's easy, straightforward. Yep. But if it is non-compressible or normal, I would not be sure that the patient has good blood flow. I think I would proceed as he showed in his algorithm, which is very nice. He actually did not even have ABI in his algorithm. He had duplex ultrasound, SPP or TCPO2, which I actually enjoyed seeing that. So if your ABI is normal or non-compressible, then I think you have two choices. Either you can do SPP or TCPO2 or go directly to angiography, because the cost of missing isolated below knee disease is so high. And you don't want to miss.
Or you could do duplex too, right, Mehdi?
Or you can do duplex too.
Yeah.
I think the bottom line and the take-home message is, you know, we've got to be looking for these patients though too. Mm-hmm. We've got to be more aggressive in running these simple tests. And I can appreciate the workflow interruption that goes on in the practice, the time that it might take. But if you assess, especially if you got a high-risk population, it's not really a difficult test to run. Let's say an ABI, but also some of the things that Raghu showed earlier in his slides. The physical appearance of PAD, it's almost unmistakable, especially when you've been doing it for a while. But you know, so this is something, it can't be out of sight, out of mind anymore. We have to do better. It's imperative that we do this.
Absolutely.
Anything else you guys want to add to that before we move on to Medi's portion?
No, I think, the axial imaging could be, could vary from place to place. And, that could be sometimes a controversial discussion, but I think more mature practices with good vascular lab support, as both of you might agree, are using less and less of axial imaging unless there is complicated bypass surgery, redo bypass surgery, and those type of things.
And I would just add one other thing, and I wonder if Raghu agrees with me. I think even with duplex ultrasound, it's very challenging to assess the distal tibials and even the pedal vessels. And as we're getting more advanced in our approach to treating these patients who have below the knee and below the ankle disease, and in trying to heal these ulcers in a timely fashion, I think that, unless you have very, very dynamic ultrasound folks, technicians, that can do those, there could be challenges in that area too.
I totally agree. Yep.
Yeah, great point. Great point. Well, let's shift gears now. Since we're talking about some of the diagnostics, let's talk a little bit about how we go about treating PAD. And again, I mentioned that, the changes and the advances in technology have certainly increased over the past 10 to 15 years. And that's been a godsend to all of us, really, as well as our patients. But yet, why do we still see this increase in overall amputations and amputation rates? So, before we get into too much of that part, let me have Dr. Shishabor discuss and give us a better overview of what's going on or what's available out there.
Well, thank you again, Desmond, and thank you, Raghu, for that wonderful presentation. You set the stage and made our job easier. Well, I just wanted to summarize one more time. As you mentioned, PAD presents in different formats. There is one thing that I hope everyone takes home. All of these patients, whether you're asymptomatic, non-lifestyle limiting claudication, lifestyle limiting claudication, or critical limb ischemia, you need to undergo lifestyle modification and risk factor modification. And I will highlight those to you in my presentation. And the reason for this is, as exactly Dr. Kalluri mentioned earlier, is that majority of these patients die from heart attack and a stroke. And we need to modify their risk factors. We need to get them to quit smoking, and we need to control the cholesterol, the blood pressure, and thin their blood. And I will show you that. And then there's this other whole group, the patients that we are talking about, Dr. Bell has mentioned, with critical limb ischemia, where we're trying to save their leg. Not only we want to save their life, but we also want to save their leg. And those patients, in addition to the risk factor modification, which we will touch on, they need additional methods to help them. And hopefully I can highlight that for you too tonight. So again, peripheral arterial disease, I'm going to go through this quickly. I think Dr. Kalluri very nicely showed this, that this is a very high prevalence of disease, and that we need to be able to identify these patients in a timely fashion. And I show this slide again because majority of the patients with PAD are asymptomatic or they have atypical pain. For this reason, you really need to look for it. Why is it important to look for it? Because PAD is CAD risk equivalent. And the way that I explain this normally is that if you have a patient with an ABI of 0.8 and you have his twin brother who just had a heart attack a week ago, both of these patients have the same risk profile going forward. The one that had a heart attack a week ago has the same risk profile going forward prognostically as the patient that has no symptoms but has an ABI of 0.8. So we need to be aggressive with both. That's why we need to look for PAD, as my colleagues have mentioned. Now, we are very passionate about critical limb ischemia, all three of us, and I wanted to a little bit show you this because I think this is a very deadly disease. When we get to this 1 to 2%, as Dr. Kalluri mentioned, these are very high-stake patients. These are people that not only are at risk of dying and a heart attack and a stroke, but also they're at risk of losing their leg. And we don't want these patients to lose their leg for obvious reasons. So 50% of patients with CLI die within 5 years. And the main problem with these patients with critical limb ischemia is revascularization. They need blood flow. These are diabetic patients. These are patients with end-stage renal disease and kidney disease that need blood flow. And that's why earlier we were talking about below the knee and below the ankle, they need a specialized interventionalists and vascular surgeons that can open the small arteries in their calf, in their foot, to be able to get the blood flow to their wound and prevent amputation. The challenge is that these group of patients, the patients with CLI, are getting sicker and sicker. This is a paper that I worked on with one of my fellows, and we showed that from 2003 to 2011, the prevalence of hypertension has increased, obesity has quadrupled, diabetes has increased, chronic kidney disease has doubled, and prior amputation in this patient population has almost doubled. So the population is getting sicker and the risk is higher. The sad news, and this is the part that I think Dr. Bell will emphasize even more on his presentation, is that these patients are not being vigorously evaluated, and many of them are undergoing amputation without even an evaluation. So this is a very famous paper by Dr. Goodnew, who is a vascular surgeon and a friend, and he asked a very simple question. He said, what was the proportion of patients that underwent a vascular procedure prior to the major amputation in the United States? And then on the y-axis, he divided the United States in different regions of intensity. So a very high intensity region would be like where I live, Cleveland, where we have university hospitals, Cleveland Clinic, Metro Health. There's a lot of academic centers, a lot of private centers taking care of patients' vascular disease. A low intensity region would be maybe an area where it's underserved, not too many medical centers, not enough care. And irrespective of whether it was in a high region center or a low intensity region, 70 to 40% of the patients in a Medicare database underwent a major amputation without even a vascular evaluation or a procedure. And this is why the three of us are here tonight, to try to convince you that please identify these patients early and let's treat them aggressively, not only to prevent them from having a heart attack and a stroke, but also prevent them from losing their leg. And there is significant disparity, as Dr. Kalluri mentioned earlier. There is geographic disparity. We have the tobacco belt. You can see this dark blue, meaning that there's a lot of amputation happening in the southern region and the Midwest region of the United States, even in the West, where you may think that there is not that much amputation happening. And then there is racial disparities. If you are white compared to black, you are 4 times more likely to undergo revascularization and 4 times less likely to undergo amputation. And we know that there's a lot of disparity going on related to vascular disease, amputation, and revascularization. And this is something that anybody that's listening to this presentation, I hope to take to the heart and pay attention to this, because many of our patients from other backgrounds may not understand the gravity. Many of my patients have told me that, Dr. Shishibor, my father lost his leg. My mother lost her leg. I thought this is normal. And it's our job to educate these patients and explain to them that it is not normal to lose your leg and be able to refer them to the right specialist. Now, this is probably the most important slide of my presentation. And instead of showing you 20 slides, 30 slides of data after data, I just wanted to distill it to the basics. I think this is the basic that any doctor that treats patients with vascular disease should know. There are 4 major medical therapies that have been shown to help reduce stroke and heart attack, cardiovascular events in patients with PAD. So these are people with claudication. These are people who are asymptomatic and have an abnormal ABI. These are people with critical limb ischemia at risk of losing their leg. Anybody that has PAD, as Dr. Kalluri nicely explained to you. These are the medications they should be on. They should be on a statin, but not just any statin. They need to be on a high-dose statin, because remember, PAD is CAD risk equivalent. So we're talking about 80 of atorvastatin or 40 of rosuvastatin. High-dose statin therapy. Number 2, they need to be consulted and referred to smoking cessation clinics. We need to change their lifestyle. Number 3, they should be on an antiplatelet therapy. Monotherapy, most guidelines recommend either aspirin. If they cannot tolerate aspirin, you can consider Plavix, clopidogrel. There is a class 2A that you could also consider them for ACE inhibitors if they have high blood pressure. Remember, many of these patients have diabetes, kidney disease, and ACE inhibitors will help them not only from a standpoint of morbidity and mortality, but also from a standpoint of their kidney function because of their diabetes and because of their chronic kidney disease. And lastly, supervised exercise program. And I will show you what I mean by that. Where does that data come from? Now, supervised exercise program, once we are past the basics, meaning the 4 things I showed you, statin therapy, smoking cessation, antiplatelet therapy, beyond these 3, then we get a little bit more specific. When it comes to exercise, obviously you cannot send the patient with an ulcer or gangrene to do exercise. So supervised exercise therapy is for patients that have claudication. If a patient has no symptoms, well, you can't really send them for supervised exercise therapy, although it would be good to encourage them to exercise. If they have ulcers or gangrene, that's also not going to work because they cannot do exercise. So supervised exercise therapy is recommended for patients who have claudication, Rutherford 2 and 3. And where does that come from? That comes from a clever trial where compared exercise therapy to stenting in a randomized fashion. The study had many limitations. Originally, it was intended to compare stents, no stents, stent plus exercise, and a stent without exercise. Because many folks in the field, including some of my colleagues on this panel, have always encouraged that revascularization and exercise, they work as a team. They work together. One doesn't replace another one. Putting a stent doesn't exercise for our patients. We still have to get them to build endurance and be able to build muscle and function and build collaterals. So just because we put a stent, that should not give the patient the sensation that they cannot or they should not exercise anymore. These things should be combined together. And basically, this is what the clever ended up doing, followed these patients. As you can see, the arm, the most important arm, in my opinion, which was supervised exercise therapy plus stenting, did not enroll patients and was not basically evaluated. So we don't know anything about that. But at the end of the day, we learned that both optimal medical therapy and supervised exercise are able to walk longer with these 2 methods. That both optimal medical therapy and stent patients had less pain, walked further, and walked faster than optimal medical therapy plus supervised exercise. So actually a stent was able to relieve the symptoms. And then optimal medical therapy and stent group had less physical limitation and better quality of life than optimal medical therapy and supervised exercise. So what's the message? The message is that I give every patient of mine who has claudication, who has PAD, I give him a prescription for supervised exercise therapy. And this is now reimbursed by Medicare. We used to complain all the time that this is not reimbursed. This is now reimbursed. Now, if they have lifestyle limiting claudication, then I also consider them for revascularization. This is again some more data showing that exercise is better than stents plus exercise is better than exercise alone. Again, it doesn't matter if it's SFA or if it's iliac. You know, angioplasty allows patients to walk more because they have less pain. It's called the MIMIC trial. Again, some data for you guys to have. So in my opinion, supervised exercise program supplements endovascular intervention and does not replace it. We should offer this to all of our patients with claudication. Now, what do the guidelines say? Well, the guidelines actually agrees with what I just told you. The guideline says that if a patient has lifestyle-limiting claudication is a class 2A to consider them for revascularization. And this is what we typically recommend. We send all of our patients with Rutherford 2 and 3 for supervised exercise therapy. And then if they have lifestyle-limiting claudication, then we offer them revascularization. And this is a quick patient. This was a 38-year-old gentleman who was sent to us for leg claudication. Dr. Kalori showed you the diagnostic testing. Again, this gentleman at rest on the right side is normal, 1.10, 0.62 on the left. But as he noted, we exercised the patient And look what happened with exercise. After we exercised him, his ABI on the left went to 0.29, very severe. So when patients tell you I have pain when I walk, this is why I do always exercise testing, because the patients usually don't have symptoms when they're at rest. They have symptoms when they walk. And it's very useful, at least for me, to see their ABI when they're walking. And 0.29 is severe. And so what can be offered to this patient? Well, it depends. If their blockage is in the aortoiliac segment, is near the inflow, is a class 1 indication for revascularization. And in this situation, actually, this patient who is 39 years old, who wants to be active, it's kind of funny, it's very similar to the case that Dr. Kaluri showed, but this is different patients. This patient had a totally occluded common iliac, and we are able to treat these patients right there and then. This is the beauty of endovascular, that right there we can go ahead and treat these patients, put 2 stents, and be able to relieve these patients' symptoms. Now, different regions in the leg have different recommendations. As I mentioned earlier, in the inflow aortoiliac segments up here, there is class 1 for revascularization, either endovascular or surgical. Nowadays, because of advances in technique, most of the procedures are done endovascularly for these patients. In the femoral popliteal, so in the SFA in this region, and these are all the different therapies that we can offer to these patients. This is a paper we worked on with Dr. Jaff many years ago, which was published in Circulation. And you can see that this is a class 2A. And then for below the knee, we generally do not recommend any intervention if the patient has claudication. If you look here in red, it says claudication. If the patient has CLI, has ulcers or gangrene, obviously that's where we put a lot of attention. We want to make sure that there's good blood flow all the way to the wound. And these are the surgical recommendations. I'm not going to bore you with this, but again, similar situation is the class 2A for SFA popliteal, but for below the knee, we do not recommend revascularization, especially surgically for claudication. Only if the patient has ulcers or gangrene would we recommend below the knee intervention for most of these patients. Now, this is my last slide, and this is with permission from the patient. This is a patient of mine who was in his 70s and early 80s, who is a sailor, very active and very smart. I met him in 2015, previously in my previous institution, and we talked about the various options. We talked about supervised exercise program. We talked about risk factor modification, and he was on statins, he was on antiplatelet therapy, he didn't smoke, he was very active. And we decided to treat him medically, and we kept treating him medically. And over the years, he kept gradually declining. And this is a graph that he drew for me. I didn't draw this graph. And then when it got to around 2013, around mid-2015, he came to me, he said, Dr. Shishabor, this is getting too much. I want to sail, I want to do a lot of things, and I cannot do it. Can you help me? So I fixed him at that time. And the next visit he came, he said, Dr. Shishabor, look what happened. I was suffering for 3 years, 4 years, and then in one day, you were able to relieve my pain. And I think the message here is that with revascularization, we can relieve pain. But we need risk factor modification and exercise to build endurance and prevent amputations and increase longevity. Thank you so much for your time.
Thank you, Dr. Shishabor. Excellent. I just have, thank you for driving home the point too about not just the amputation prevention, but trying to prevent heart attack and stroke, because that's a big part of our mission with Save a Leg, Save a Life. That's what it really means. It's not only about preventing amputation, but it's about that very thing. But I just want to ask a quick question. Is it safe to assume that if somebody comes into your practice, they've got a history of coronary disease, is it safe to assume that they also have a history of PAD that's been undiagnosed?
And the answer to this is that most likely you are correct. I wouldn't say 100%, but most likely you are correct. And this is what others have shown, to be honest with you. This is what others have shown, that patients who have coronary artery disease have PAD, and patients that have PAD have coronary artery disease. So I think it's extremely important that we look at it both ways. If you have patients with PAD, many of them are not very active because they get pain. So you ask them, do you have chest pain? They say no. But then you ask them, how much do you walk? Well, I don't walk, doctor, because my leg hurts when I walk. So it goes both ways. You're absolutely correct. You should be vigilant in both directions.
Thank you for that. Okay, and with that, I'd like to now tie this together by discussing the podiatrist's perspective on the team approach to peripheral arterial disease and treatment. So, you know, again, the Save a Leg, Save a Life Foundation, we've started this White Sock campaign, which I discussed a little bit earlier, and we'd certainly love to get you involved. Instead of me just blathering on for a few minutes, I would like to really drive home a really important point of why we're doing this program in the first place. And that is, instead of talking about things, I want this to be a call to action. I want to show you how simple this really is to screen for PAD. I fully understand that we have workflow issues within our practices, and I want to just kind of give you a strategy, because one of the things that we've noticed too over the past few years is that patients are getting younger, and this is really disturbing, among other things. So with that, I'd like to just get this going.
So we're going to show you how simple a PAD screening can be. And for patients out there, there's nothing to fear. In fact, if you're worried about who's going to pay for this, your insurance will absolutely cover this. PAD screening, if you're diabetic and if you're a smoker who's age 50 or above, even if you're age 70 and above and you're in good health, the American Heart Association, the American College of Cardiology recommend that you be screened at least once a year. So I'm the physician today, and I apologize for not wearing gloves, but hey, you know what? It's a minor detail for this. There are no open wounds here. I'm with my friend and patient, Carla. Just so you know, Carla's got a long history of PAD, and we'll get into that in a little bit. But as a provider, when I first walk into the room, I want to see certain things. And for you patients out there, what I want you to do is make sure that you take your shoes and socks off. And that is such an important thing. So often, our doctors are too busy to even look at our feet and legs, and yet, you know, that simple cue by having your shoes and socks off will kind of guide them to do that. And for you physicians out there, by all means, have your staff take the shoes and socks off. It takes all of about 10 seconds to do that. So, no excuses. Today, it's not only about awareness, but it's about a call to action. So the first thing I'm going to do when I look at my patient is I'm going to assess their feet. I'm looking for basic color. Now, you may not be able to see how red Carla's toes are, but again, one of the early indicators of PAD can be this discoloration, either too red or kind of dusky or even bluish color. All it could be indicators of a decrease in oxygenation to the tissue. So I'm looking at that, and then I'm also looking at how long it takes for the color to return to her toes. And in this case, it's pretty quick, but anything over, let's say, 3 seconds would be a concern. Now, her feet also are nice and warm. Also very, very important. I haven't even started doing her pulse assessment, so that's what we're going to do next. So Carl, I'll have you swing around, make yourself comfortable. And again, this only took a few seconds. Now I'm going to palpate for pulses, but before I do that, I'm going to feel the warmth of her leg. And it's normal to have a little bit of cooling as you go more distally. And in her case, it's pretty warm today, so this is a great sign. Now, I'm going to feel pulses, the dorsalis pedis pulses. You know, just because somebody has palpable pulses does not mean that they have adequate blood flow. It's an important part to remember. Checking the posterior tibial pulses. And again, this is really, really a simple process. And that's it. A couple other things that I'm looking for now too is the presence of hair or absence of. I'm also assessing her skin. It's not uncommon to have some type of discoloration or a brown staining of the skin. Just because somebody has that doesn't mean that they have venous insufficiency. People that have arterial disease a lot of times have venous insufficiency and vice versa. Also, diabetes can cause this. So we're looking for overall dryness of the skin, also looking for any potential wounds. Make sure you check in between the toes too. Very, very important. Check the heels. Look for characteristic ulcers that can be forming on the tip of the toe, especially on the great toe. It's not uncommon to see a little black eschar or a black scab forming there. So there's the first part of our examination. Now we're going to get into something else. You know, I mentioned a couple minutes ago about taking pulses. I've been doing this for a long time, and I don't trust my own palpation ability or the ability to feel pulses. I have strong pulses in my fingers. So it's not uncommon for people to feel for pulses and be misled. So one of the things that I like to do is use a handheld Doppler. It's really simple, and I'll show you how simple it is. Have a little bit of gel on hand. Just put it where the dorsalis pedis artery, the posterior tibial artery, and we'll even do a bonus artery today, the perineal artery. Let's turn on our Doppler. Pretty simple. And if you can hear that, it's a pretty good signal. Now we'll do the other foot. Now we'll do the artery that supplies the bottom of the foot, the posterior tibial, or the tibial artery. Pretty simple. That's all it takes. And from what I can tell today, Carla's got some pretty good blood flow going down to both feet. And it's important that in her situation, because she's had a history of PAD and she's had stenting and some other procedures done, that she'd be reevaluated periodically, because you've got vessels on both legs, both feet, and you know, sometimes physicians will get in there and do some work, open up a blocked vessel, just the way they would do a coronary artery. But the point is that somebody who's at high risk should be checked at least once a year. And if they do have a history of having some type of procedures done, by all means, having a repeat evaluation maybe every 3 or 4 months too is certainly beneficial. So now we're going to go on to the next phase of this. So now we're going to demonstrate one of the simple ways to do study called an ankle brachial index. Now, this is an examination that is not invasive, it's very simple, it's very quick to perform, and it's a great screening tool for peripheral arterial disease. You know, you think about it, when your doctor walks into the room, one of the first things he's going to do is, or she is going to do, they're going to pull out their stethoscope and listen to your heart. I want you to think in terms of why we do PAD screening. It's important for a number of reasons, obviously. But you all know the symptoms of a heart attack. It could be something like chest pain. Well, I want you to start thinking in terms of a foot attack, okay? If somebody's walking and they have pain in their calf or buttocks region, that could be a symptom of significant peripheral arterial disease. And a lot of times, there's that connection between what's going on in the foot and the leg, as well as in the heart or even the carotid arteries. So when we say save a leg, save a life, we're trying to prevent not only catastrophic events such as a heart attack, or such as an amputation, but also a heart attack or stroke. So we're not only trying to prevent amputation, remember, again, saving legs and saving lives, very, very important. So this is a simple thing, and really today what we're trying to do again is eliminate all the excuses as to why people are not being screened, and again, showing how easy it is to do. So the ankle brachial index basically is a ratio, and it looks at the blood pressure in the arm and in the ankles or the foot. So hence the term ankle brachial index, and it's really simple to do. Now the device we have set up on Carla today involves blood pressure cuffs on both her ankles and on her arm, and it's as simple as a press of a button. So the amount of time to set this up took maybe about a minute tops. And now to get the information that will really be helpful to determine whether we need to send Carla for additional testing or to make a referral will really be at her disposal pretty quickly. So again, this is really, really simple. It's already giving me information, and I'm seeing from here, and I know you probably can't see it on your screen, but we're looking at waveforms. And for the patients out there or your caregivers, what I'm looking at is kind of like an EKG for the lower extremity. And there are some telltale things that we can look for to determine if there might be a blockage in the leg that could be leading towards not enough blood flow getting to the foot or the toes, and can be causing some of those symptoms that we were talking about. So that took all of about a minute. So now, all total today, between taking shoes and socks off, between feeling for pulses, between putting a Doppler on, or even doing an ankle brachial index, it's taken about maybe 5 minutes tops at best. So again, we have to kind of put those excuses away as to why we're not doing these very, very important and potentially life-saving exams. So I'm back talking with my friend Carla, and we just did a whole series of simple examinations for PAD. Carla's been a trooper through all this. I mentioned earlier that she had a story to tell, and so I was thinking back today too. When we first met, it's over 10 years now.
Yes.
And Carla came to me with basically a pretty grim looking prognosis. She had been to several big medical centers. One was in Thailand where she was receiving stem cell treatment, and then locally she was told it was time for balloon amputation. And how old were you at that point? Was it?
Wow. All the problems started in my late 30s.
Yeah. And I remember you had already had a bypass surgery too.
Right. I've actually now had 2 failed bypass surgeries.
So, you know, when I met Carla too, she had black scabs on her toes. She was in a lot of pain too. And really, had it not been for some of the technology that's available nowadays, and that was starting to emerge back then, she probably would have been another statistic. And I still remember you saying to me, your goals in life were to see grandkids, and so here you are, you're a grandma.
Yeah, she's going on 6 years old now.
Yep, and she started another business too.
Yes, actually.
So tell people a little bit about
Actually,
what you do.
I'm in the wedding industry, and I do the decorating end of it, so it's very physical, a lot of weightlifting and moving, and I absolutely love it. I'm also in the towing industry, so I have 4 jobs actually, and I'm just a go-getter. I'm a doer. So, and that was my biggest fear too, was being slowed down. I can't stand to sit still. So
That I
yeah.
know. When she said towing industry, it has nothing to do with those toes, but
Not
I'm
those
happy to
toes.
report she still has all 10.
Yeah, I've never lost a digit.
No, it's been nothing short of a miracle, but you know, this is why we do what we do. And it's kind of that gift of a second chance too, that, you know, if you think that this is not important, think again. So anyway, I'm glad you're here. Okay.
Thank you.
You bet.
Thanks for
helping
being
me.
my friend, and thank you for believing in me, and I surely
course.
believe in you.
Oh, likewise.
So you heard Dr. Shishabor just mentioning the incidence of people having intervention and high population or high incidence populations, I should say. Well, that was not the first time I had ever heard data that was similar to this. Years ago, I was in a conference room and I heard Dr. David Ali explain basically the same thing, that 50% of lower extremity amputations are performed in the US as a first-line intervention and without any prior vascular testing. And that, in a nutshell, kind of blew me away, but made me realize that we are missing the boat on this and that we need to be far more aggressive with our approach to PAD assessment. And these numbers were further validated by the SAGE group too. What's also interesting too, that minor amputees experience adverse events the same as major amputees. So even losing a toe or a half a foot is wrought with all sorts of potential issues. So really, what's really struck me though was that the decision, if you really think about that statement, the decision to amputate is often based on subjective opinion versus objective findings, because 50% of these people at least are not having any type of vascular testing done prior to amputation. It's that initial consultation and then right to the OR. So I kind of say that third world medicine is being practiced here in the US where amputation is concerned, and that's got to change. So how do podiatrists fit in? Well, Duke University ran a study a few years back and found that patients who had only seen a podiatrist had far less lower extremity complications, I should say, and also reduced the risk of amputation compared to those who did not see a podiatrist. And it's all about the multidisciplinary team being responsible for reducing amputation. Economically, we know that preserving the lower extremity is so much more important than amputating. And this is not just that initial amputation that's being done, but it's what happens afterwards too. The aftercare, even the changes to a living space should the patient actually make it home after that. So this is really, really a call to action tonight. There's also, again, this study that I'm referring to, though, showed that care by podiatrists prior to the first evidence of foot ulcers in patients prevents or delays lower extremity amputations and hospitalizations. So again, it's being proactive. It's being proactive versus being reactive, being aggressive in how we approach the evaluation of these patients. And again, this holds true whether it's in Medicare populations or non-Medicare populations. Bottom line is podiatrists, though, are the gatekeepers of the amputation prevention team. Our duty is to evaluate that foot ulcer, but prior to that foot ulcer developing, we're the ones who have to be checking out to make sure that there's no underlying cause such as PAD. And we've got to make those referrals too. You can't sit on these patients. You can't hold on to them. You know, we're not looking just to rule out PAD, but we're also looking to find those scenarios, those risk factors where it might be found. So Dr. Shishabor, Dr. Kaluri already touched on this in a sense, but we've got to be the ones who will be the ones to do the preliminary testing. And if you feel like it's over your head or out of your comfort level, by all means refer. Send to somebody who will do that, whether it's an interventionist or even a hospital setting where they can run testing. Please get them tested. So what is our job, though? If we're talking about PAD, our job is being in the front line. We have to be the ones who identify it. We can't be confusing symptoms of peripheral neuropathy with PAD. Just because somebody has numbness or tingling or pain in their lower extremity doesn't mean that it's from PAD or from neuropathy if they happen to be diabetic. So knowing how to address PAD and identify it properly is so important. And you saw that in the video. And also identify those critical limb ischemia patients, such as we're looking at right now. But again, knowing how to make that referral and building up that team. So educating your patients is a big part of this. You know, we can only do so much. And with the advent of telemedicine, really since COVID, or I should say with telemedicine being pushed to the forefront, we can actually do a better job monitoring our patients now. We've got to constantly be evaluating all sorts of things, though, when it comes to amputation prevention. And these are some of the things that we do. But managing those comorbidities that we've already talked about tonight, diabetes, heart disease, hyperlipidemia are certainly important, and they contribute to PAD. So if you look at the things that podiatrists do, who are going to do some of the things that we do? It's not going to be the plastic surgeons. It's certainly not always going to be some of these other specialists. They all have a role in the team, but their time is spent in other areas. So we're the ones as podiatrists who can be the ones making that initial call and making that referral, being the point guard of the team. So what's happening when somebody presents to an ER? I want to shift gears a little bit right now. When your patient shows up into an emergency department looking like this, what's going to happen? And I'm asking, are there protocols in your hospital that are established, especially when CLI is impending? Is amputation based then on what we were just talking about? Is it on subjective opinion or is it based on objective findings? And why I'm asking that is, again, what's the protocol? Are there tests that are automatically going to be run? Is there some type of algorithm to follow? So let's talk about this. What's the standard of care in your hospital? Is there a standard of care? Bottom line is, before proceeding to amputation, expedited vascular testing must be performed. That's a must. Just by doing that, guaranteed you will reduce the number of amputations. We have technology available. So I just want to tell a little story. A few years ago, I had presented up in Asheville, North Carolina at a little hospital up there, and it was for our foundation, and it sparked something in one of our attendees, and unbeknownst to me, a few years later, I would run into her again at a conference, and she pulled up to me, and she came up to me and said, Dr. Bell, you know, we started doing some of these things in our hospital, and it's amazing. just by looking, just by running the tests, our amputation rates went down. So this is why something where I say being proactive versus reactive is such an important concept. It's time to expand that message of PAD and critical limb ischemia awareness to the public. We've got to get them involved. Primary care physicians, emergency departments are vital factors in this, and we've got to target them. And prevention is still the best and most aggressive action that needs to be promoted and taken. So remember, in this high-risk population, this is no longer adequate. Just simply feeling for pulses or even doing a simple ABI in the office on a high-risk patient is not something that you should put all your faith in. Remember, absent pulses can be an indicator of no flow, but palpable pulses are never an indicator of sufficient flow. And remember, remove your shoes and your socks. Primary care physicians especially. Before you walk in that room, train your staff to take the patient's shoes and socks off. I can't stress this is enough. As a practitioner for many years, as a wound specialist for many years, I can't tell you how many times that I've had patients come to my practice with open wounds or ischemic changes on their feet or lower extremity, and I'll ask the question, when was the last time you saw your primary care doctor? And I'll get the answer, I saw them last week or 2 weeks ago. So the point is, out of sight, out of mind is not going to cut it in this group. Screen your patients for PAD. You saw how easy it is tonight. And just remember that amputation should not be seen as a treatment option, but as a treatment failure. So thank you very much. Okay, we'll get some questions answered now. We appreciate everybody's input, and we've got some good ones. Some a little more basic, but nevertheless, good information to impart here. So I'm going to start off the question. The first one that came in was, what is the difference between the terms PVD and PAD? Sounds kind of basic, and it's pretty simple, straightforward answer. Dr. Kalluri, you feel like taking that one?
Yeah. So after spending, fellowship in vascular training, and now running the Vascular Medicine Society for Vascular Medicine, V stands for vascular disorders in general. So while PVD was used for arterial blockages, we've gotten away with it because the vascular system has arteries, veins, lymphatics. All of that fall under the greater vascular disease umbrella, but PAD is peripheral artery disease.
Perfect. Pretty straightforward. Arteries versus all the other components. So keeping it simple is what we're all about here. Here's another one too. Given that ultrasound is not covered as a screening tool as recommended by the USPSTF, nor reimbursed by CMS as a screening tool, what other choices are available in the primary care setting? And this is a good one because really ultrasound is more of a diagnostic versus a screening tool, and there's a difference there. Mehdi, how would you expound on that a bit?
No, I totally agree, and I think you hit it on the nail on the head. I don't think you need ultrasound, in my opinion, as a screening tool. You need it for AAA. So if you wanted to rule out AAA, and that is reimbursed actually, for the right patient population, and we can discuss that if you like. But since we're talking about PAD, I think that an ABI is a very good screening tool if you want to identify patients that have vascular disease. And, it's pretty straightforward to do and not as extensive as an ultrasound. So now, whether it's reimbursed or not, ABI, I am not sure about that. Raghu, you may know better than I do. I
if I may interrupt, Mehdi, I think the person who asked the question is trying to say, given that ABI is not covered, because screening ABIs are not covered.
Right. ABI is not covered either. I agree with you. Yeah. So, but I think that I think that there is so much benefit that comes from this, in my opinion. At least in my institution, we routinely screen patients if we have concerns, of the patients that Dr. Kalluri in his presentation highlighted. Who are the high-risk patients? Well, folks over the age of 65, anybody that's a smoker, those with diabetes, those are the folks that we have studied in the past. And then there is a subgroup of other patients that these are in asymptomatic screening we're talking about. And then obviously if the patient has any kind of a symptom, that's different ballgame. that just changes everything. But we have learned that there is a lot of benefit that comes when you identify a patient with PAD, not only from a standpoint of lifestyle modification, but sometimes you'll be surprised that when you identify the disease and you ask the right questions, symptoms actually come out too. We have learned, and Raghu, you're shaking your head. If you want to add anything, please go ahead.
No, all I'm saying is, everything that you said is right. But I think, most of this question comes up because of billing issues and how do you get a CMS approved billing, I think is what this question is alluding to. Like you said, if you have symptoms and document that the patient has claudication, it's covered. If you like you said, Betty, I mean, grabbing those patients with risk factors, documenting that they have claudication symptoms or diminished pulse is another approved indication for getting an ABI reimbursed. So physical exam and history is enough to get it paid rather than blanket screening everybody over 50 years of age.
I appreciate you both addressing that. I just want to add a little bit to this because this is one of the real reasons that we even came up with this concept this evening. It's really the fact that so many times the primary care physicians or the podiatrists are seeing these high-risk patients in their practice and they're not even looking. Okay, so let's talk about screening. Screening is just is really, if you get right down to it, it's identifying those people who are at risk. It doesn't mean that you have to, let's put all the billing part of it out of it. First of all, it's doing good medicine. But I want to say, my point of frustration really comes from the fact that many times over the course of seeing patients in my practice, which has primarily been a wound care limb preservation practice, but I would see patients who had been to their primary care doc, let's say the week before, and I'd ask them when I'd take their shoes and socks off and they have an open wound, well, when's the last time you were at your doc? Oh, I was just there. Did they ever look? No. So it sounds simple, but we're not talking even high tech. Just keep in mind how important it is to just know your patients, know who's at risk, but get those shoes and socks off. It's a simple exercise. I can't overstate that enough. It's such an important part of this before we jump into the more heavy diagnostics. So that's me pontificating here, but it's important. So let's move on to the next question then. So, and Dr. Shishabor covered some of this evening in his topic. What is the protocol for completing exercise ABIs? So, Mehdi, you want to take that one?
Sure. As I mentioned in my presentation, first of all, I think it's extremely valuable to me because these patients come to us with symptoms when they walk. When you do a resting ABI, you're not getting a true perfusion of a patient, when they're having their symptoms. It's the same reason why when we do, stress test for the heart, we stress the heart. We just don't do it at rest. So getting the numbers while the patient is exercising is extremely important. There are different protocols that can be used. In my opinion, the best one is on the treadmill. People have done toe raises and other forms, and Raghu is more of an expert in this than I am, and he can comment on it. But I can tell you that I think the one that truly gets the numbers is the exercise one. And the protocol is usually 5 minutes with 12% incline. And you basically let the patient do the walking, do their best while they're walking. And most of the time you can elicit the symptoms. So it helps you to understand, is this the same symptom that they're having that they're describing to you? And then you get the numbers, obviously, after the exercise so that you can compare, okay, the patient had this symptom. What was their blood flow at the time when they were having the symptoms? Raghu, please, if did I say it correctly? Did I pass?
Absolutely. I got nothing else to add. You did a great job.
So, awesome, Betty. So somebody else asked a question too. Where can you find a supervised exercise program? That's a great question. If either one of you guys want to follow up, and then I'll chime in too.
I can doctor to that. That's a great question. And we have, and Raghu and you probably, Des, and all of us have fought for many, many years to get this one reimbursed. This was a fight of the centuries. As you know, a supervised exercise program, which in my opinion, every patient with symptomatic PAD should at least be prescribed this supervised exercise program for PAD was not reimbursed. I mean, we are worried about ABI, something that's been shown multiple, 40 trials? I don't know, some incredible number. But we just got it approved. Many folks were players. Raghu was leading this, and is now reimbursed. So every patient that you have that has symptomatic claudication, in my opinion, should be given a prescription for supervised exercise program for PAD. Now, you asked a very good question. Where do you find it? In my opinion, there is still very limited availability of this. Now that it's reimbursed, I think it's becoming more and more common, and people are engaging it. That the approach is a little bit different than cardiac rehab, as you know. So for that reason, you need to look around and obviously find where near you offers that. The patient is a prescription for it, and they can get it. And I think it's very effective. Raghu, again, please comment.
Completely agree. This was a struggle. It is approved now. Yesterday, I sent 2 of my patients for supervised exercise program in our center. So you have to just, I think in terms of where to get that for the question, I think you have to talk to your local vascular specialists. Most of the health systems are running these in the same centers as cardiac rehab. That's where we have. In fact, on the EPIC orders, there's no supervised exercise program order. We still say cardiac rehab, and in comments we say supervised exercise program for peripheral artery disease. And then at the back end, our exercise physiologists take care of it. But that's in terms of where to find it. I think you need to, get a hold of your good vascular specialist friend.
Good point. And I think, again, a starting point would certainly be if you have a cardiac rehab exercise facility within your hospital. I know mine here in Jacksonville, Florida, we had one. I'd see those guys at 7 a.m. Every morning lining up to go in there, which is great. So that's a good starting point if you don't know where else to look. Okay, so far, excellent questions. We've got more coming in.
I don't have the link, but I saw during the pandemic, because people could not go to the supervised exercise program centers, NHS in the United Kingdom came up with a home regimen sort of thing that you could do on your own too. It's not that difficult, but in folks who have multiple comorbidities, it's a fantastic thing to have an exercise physiologist right there. But there are times where I recommend, home unsupervised exercise program for these patients.
Yeah, and you just triggered something too for me, Raghu. I think, you could also check with some of your home health agencies. Some of the rehab facilities have outpatient or home visits, and I know they have gait training. They have, besides their occupational therapy, they'll have balance training. So, I would inquire. They may have those type of programs too. Maybe some of the more, larger agencies would be more apt to have something like that as well. So again, great question. It's so important to get these people moving, but the importance of supervision can't be, overstated. It's really, really important. Okay, so here's another one. Most primary care physicians' offices are not equipped with ABI machines. What other choices are available? Great question. Starting out, again, shoes and socks, take them off, doing that physical examination we talked about. Something as simple as a Doppler, you can perform the ABI with blood pressure cuffs and a Doppler. There is some potential for user error, and again, it could take a little bit more time, but there are some other devices too that would qualify as screening type devices that can be used. Without promoting anybody, I know years ago I used to use a PadNet system in my office, which provided ABIs and waveforms. Kind of leads into one of the other questions that came up. Do you guys have any other things to add to this? Again, primary care office, we understand that there's limited time and really, doing the vascular testing is not part of it. But again, it's that screening. Just get them identified so you can make the referral. That's the key.
There's a couple of things that I have done, and I think that, unfortunately we don't do as well, and is using the stethoscope, to be honest with you. Right. If you hear any bruise in the carotids, if you hear bruise in the groin, if you hear bruise anywhere, there is vascular disease. So I think that, that, and every primary care doctor has one of those. I don't know, podiatrists may not have them. I don't know, Des, you carry a stethoscope?
I always had one, but I just.
I know you would.
I would always put the Doppler on them. That was my go-to. But Mehdi, you brought up a good point, because as a podiatrist, though, as I would be interviewing a patient for the first time, I'm looking at their medical history, and most of my patients were diabetic, and so most of them had coronary disease. I assume that they have peripheral disease. And then I work backwards, and so that was my mindset. And then say, oh, do you know what PAD is? Or you start talking, oh yeah, I had some stents in my heart. And well, and it just becomes a teaching moment too. And so that's kind of when I say screening, that's part of it as well.
Looking forwards, I don't think this is going to matter, because with the point of care ultrasounds, for example, I take that in with me for the patient. I don't even listen to carotid bruit anymore. As I'm talking to them, I'm looking at their carotids. They're in shorts. I'm looking at their at their SFAs. And by the time I'm out, I even can send some of these critical limb ischemia patients directly to the cath lab, to one of my partners, telling them whether the contralateral side is open or not, for access and those type of things. So I think, as the POCUS, the point of care ultrasound, becomes cheaper and cheaper and more affordable, I think it is going to, it's going to augment. I don't want to say, replace, but I think it's going to augment physical exam. It's bound to happen.
That's a great point.
Absolutely. Well, here's another one that kind of falls into this line. I kind of alluded to one of the devices that I used to use. Can you please address the value of pulse volume waveforms with ABI versus ABI alone? This is a great point, because especially when you're dealing with the high-risk patients who we know have a lot of times non-compressible vessels because they've got so much calcification going on, it can falsely elevate those ankle brachial indexes. And so the waveforms are going to give you a visual that will be indicative too of the type of flow that there is, but between segments as well. So if there is potentially a blockage or some type of stenosis or occlusion, you can probably kind of pinpoint or zero in on where it is. But I just want to throw one thing here. Years ago, I would run these type tests in my office where I had the waveform and the ankle brachial index. And a really interesting phenomenon started happening. I was getting many, many normal ABIs, but the patients had waveforms that were indicative of significant peripheral arterial disease. In fact, I looked at 75 patients, and of those 75 who had quote unquote normal ankle brachial indexes, I also found that 9 had critical limb ischemia or monophasic blood flow, and I think I had about 36 that were significant. So, the point is the screening is important. The ABI is very, very important to do that. But you also have to recognize too that some people are going to have some false numbers, and if it's just one thing to look at. Don't rely on that only. And I'll defer now to my colleagues here, because I'm sure from their standpoint they have something to add on this.
So pulse volume recordings, I covered that in my lecture earlier. So everything that you have said, Des, is true. And in a well-trained vascular lab, sonographers, although ABI is a simple test, there's still an art to it. sonographers who and pulse volume recordings give a lot of information, and not every lab does a pulse volume recording. That's an important thing to remember too, because you're right. It adds a lot of value, especially in those non-compressible stiff vessels, because you're basically impeding the venous flow, and the PPG sensor is just sensing the volume changes, assuming that the leg is a cylinder. Now, these morbidly obese, the ultra thin, the cuff size, the width, and all those things do make some, interesting artifacts. And if the cuff is not snugly applied, you might artificially create a problem with pulse volume recordings also. For all those reasons, I think pulse volume recordings are a great adjunctive tool to ankle brachial index and segmental pressures to assess disease, if only if the clinical picture doesn't make sense, and if the ABIs don't make sense. Segmental pressures, they're useful, just like you're saying. Instead of segmental pressures, you can look at how the waveforms are changing from one level to the other. I just love pulse volume recordings and the physiology behind it, and I can keep going on and on and on.
I hear you, man. I agree with you.
Yeah.
Dr. Shishwar, anything else to add on that one?
That was perfect. You covered it.
Okay. Let's see. There's at least one more here. Okay. If the ABI is indicative of PAD, is it necessary to get a CTA before referral to vascular? Maddie, why don't you take this one?
Yeah, no, I would not do that, please, because it's for a number of reasons.
We knew that was going to happen. I thought it was going to be at my house, though.
The dog agrees with me. Even the dogs agree with me. I love that. So no, I definitely don't do that, please. I think that radiation and contrast, that is unnecessary. I think that there is a lot of things that go into the fact that whether somebody needs a treatment. Obviously, their symptoms is one, location of the disease. I think the things that we talked about, PVR, segmental PVR, ABI, PVR with exercise, those things are very valuable. They can give us a lot of information. Ultrasound is extremely valuable. So I rely heavily on things that don't require contrast and radiation. So that's what I would recommend for majority of the patients, and leave the CT for the specialist that's maybe they need to treat the patient and they have a question. They're not sure about something. They can then get a CT. But to routinely do CT on every patient with abnormal ABI, I would highly recommend against that. I don't know my colleagues here, what their feelings is.
I think Dr. Kaluri's volume, something happened.
How is that better? Better?
Better,
Yeah.
there you go.
Sorry, the dog effect there, the barking effect, as you can imagine, I got startled.
Must be an Amazon delivery.
As I mentioned in my talk, the reliance on axial imaging for everything that Dr. Shishwar said has gone down significantly, and since the duplex ultrasound, clinical examination, ABIs, point of care ultrasound are so advanced now that you can get all of that information without exposing the patient to ionizing contrast and radiation.
Yeah, very important point. Absolutely. So we have one more here that I think is maybe a couple more come in. And here's the latest one that I have. And I'll take this one because it's relevant to me. But how would a podiatrist, cardiologist, and surgeon all work together best to treat a patient with PAD? What is that patient pathway? Great question. So, we've been talking about the team approach, and we're all represented here because, I, as a podiatrist, in a sense, I'm the point man, but so are the primary care physicians too. And it's our job to recognize these patients who are at risk, who are having symptoms, and then to make that referral. again, on the topic of simple questions you can ask your patient, and a lot of the screening actually does happen before you even lay hands. You walk in that room, and if those shoes and socks are off, if you see somebody's sitting there and their feet are dangling and they've got rubor or cyanotic appearing lower extremity, you know that there's something going on. And to me, that would be reason to make a referral right there. But then question them too. Great question I would always ask, which I learned from one of my interventional cardiologist colleagues, was, can you lay in bed at night? Or do you have to sleep with your foot dangling off the side of the bed? Many of our patients sleep sitting up because they're allowing gravity to try and pull blood flow down to their lower extremity. So these are things that to me are a red flag and would be warranting of a referral. And then how we work together, I would do the wound care and refer to my interventionist friends, and then they refer them back to me. I would do my surgery then if needed. And so it's a constant back and forth. And let's say even after intervention has been done, it's so important to continue the follow-up because we're dealing with multisegmental disease, bilateral disease. So just because maybe one area has been repaired doesn't mean that they're not still at risk and things can reocclude or another vessel. So I've always been constantly looking and watching these high-risk patients especially who have had intervention, to make sure that, okay, just because they've had procedure done doesn't mean we forget about them. You have to be in constant contact, and that's how you build the team too. So thanks for letting me do my little explanation there. Either one of you guys want to add to that? And again, I just want to clarify too, for about 4 years, I was part of an endovascular, or I should say an interventional cardiology practice. So we actually brought the concept under one roof. For years, I would work with other specialists in my community. Then ultimately, I moved and merged into one practice and found it really very efficient and a very, it was a model that provided continuity of care, and it prevented from some of these patients from falling through the cracks and from, maybe showing up in the ER afterwards. So, again, can't stress enough, you just have to stay on top of these people, just the way you would with a cancer patient. David Armstrong was one of my colleagues in the podiatry world, talks about healing up a wound. And he says, once it's healed, it's in remission. And you should be thinking that too. These patients are medical time bombs, really. They can go bad very quickly. So it's imperative to stay on top of them and to monitor them closely.
Well, Des, I can say one quick sentence is that we have a lot of primary care doctors on this call. And I really believe that, they have a duty and they have the power to be the gatekeeper for the patient and to be an advocate for their patients. Unfortunately, I think that sometimes, our feelings, our egos, our ideas, our ideologies interfere with what's right for the patient. And as a specialist, in my opinion, I'm just talking about myself. But I do believe that the primary care doctors have the best relationship with their patients. They typically know who does what, and they should advocate for their patients. They should want the best team to take care of their patients. And I hope that, each of the folks that are on the call tonight take that to the heart, that if they feel that Dr. Mehdi is not able to offer the best care in this particular situation, and Dr. Kalluri can, well, you know what, I'm going to send Dr. Kalluri. And I can tell you that, most specialists actually respect those doctors, and they step it up because they know that, listen, if I want the referral from Dr. Bell, I better step it up because he ain't going to send it to me if I'm just going to do average care. Right. So there's a lot of power that our podiatrists and our primary care doctors have, and I hope they take advantage of that because we want their business, we want to work with them, and we will step it up. If they demand it, we're going to step it up. And if we don't step it up, we don't deserve their patients. That's my view of it.
Yeah, if I may add, I think, I think taking the specialty out, like cardiology or vascular surgery or vascular medicine out, and having more of a team concept is what the primary care doctors need to look at. Each area is different. Not all podiatrists do wound care. Not all podiatrists take care of vascular patients. Not all cardiologists take care of vascular disease. Not all vascular surgeons may do wound care. So, you have to figure out, what works the best in your own community. So each place could be different. We have our own critical limb center. We don't call it a wound center, with 8 of our podiatry colleagues, 2 vascular medicine, about 7 interventional cardiologists who practice vascular only, and an army of nurse practitioners. So, each place is different. And we have 4 vascular surgeons too now. So not everybody in every institution has all specialty representation. So, but it is easy to find what that vascular program is in your neighborhood, and then find out where to send that patient and who the gatekeeper would be there.
It's absolutely, ultimately, at the end of the day, it's communication and learning and developing those relationships within the community through. Sometimes it takes a little trial and error, but it can be done. And fortunately, there are more people who are embracing this skill set of the interventionist, and we have more technology to offer our patients that makes this less traumatic. So, the point is, we want to prevent these patients from turning into critical limb ischemia patients, prevent them from becoming amputees. Patients will hide things from you too. They're really good at it. They hide things from their own family members, not taking their shoes and socks off. Like, I keep dwelling on this, but I've had some crazy things happen over the years. So you've got to sometimes pull it out of them a bit. Anyway, we're kind of winding down, so I want to give you each one chance to maybe add some more thoughts before I finally put a close on this evening, which has been fantastic, by the way. So Raghu, I'll let you go first.
Okay. I thought you were going to ask Mary first, but thank you.
I faked you out.
I get the benefit of your wisdom. I get the benefit of your wisdom.
Well, the key we've been talking about in PAD, it's a huge burden. It's a heart attack equivalent. So think about it, look for it, find it. That's all I got to say.
Yep.
And I'm going to go a little bit longer because, people know I like to talk. But I want to tell a quick story, Des, if you allow me. Quick.
You have my...
Morning, I was rounding in the CICU. This is a true story, just happened this morning. And we had a patient with a toe ulcer that was in the ICU for a different reason, but we found the toe ulcer. I asked 5 residents and 3 fellows, how do you do an ABI at bedside? And not a single one of them knew how to do it. So there is so much awareness that needs to happen. And I want to say kudos to you, Des, for leading this program. And kudos to the people that are on this call for wanting to learn about PAD. And what an appropriate month to advocate for our patients that have vascular disease. It's a serious disease, as Raghu just said, is CAD risk equivalent. People lose their leg, they get a stroke from this. There is a lot of stuff that happens when you have arterial disease. So thank you all, and thank you for having me here tonight. I learned a lot, and it was great. It was fun. Thank you.
I appreciate the kind words. And, I think I'll wrap it up too on, Raghu, you talked about the equivalent of a heart attack. We call it a foot attack sometimes. And we need to have protocols in line, even in an emergency department, before somebody goes to amputation. If they present with a cold or an ischemic looking leg, we need to have some type of testing done, because we're still at this point where half the amputations done in our country are done without even any prior vascular testing. That's crazy. But the name Save a Leg, Save a Life, when we came up with this, when it kind of came to me one day, I realized it was not only about preventing amputations, but it's about connecting the dots. We're trying to prevent catastrophic events such as heart attack and stroke, as well as amputation. And really, it's about quality of life for these people. So we have the ability to do better. We have technology and people like my colleagues who are willing to do this work. But if we don't identify these people and get them to the right specialists, they end up showing up in the emergency department, or something catastrophic again happens. We don't want to wait until it's too late. So with that, I want to thank everybody for attending. Please remember, keep doing the great work you're doing. Wear those white socks, take pictures, post them on social media. And until next time, thanks very much for my colleagues, Dr. Mehdi Shishabor, Raghu Kalori. I'm
Thank
Dr.
you.
Desmond Bell. Thank you very much.